So at the educational session this year, I talked about less is more in terms of de-escalating the intensity of systemic chemotherapy for breast cancer. And it's actually a very interesting area where we've made significant progress. And the idea is that by doing new studies, we've made incremental improvements in the outcome of early stage breast cancer, reducing distant recurrence and improving survival. These are small changes over time, but every study involves taking what we do already and adding to it so that we just keep escalating the treatment we're giving. And that increases toxicity, cost, and sometimes the time that patients spend receiving treatment and suffering the side effects. There are also long-term side effects to be considered. So now that we have a better understanding of the biology of breast cancer, we have some insights into who needs more or less treatment. For example, we have these gene expression assays now that can help us identify a group of women who have very low risk of distant recurrence who clearly don't need chemotherapy. So that's one group where we're going to treat them with hormone therapy alone. We also have some genomic predictors that have given us a window into women who have hormone receptor positive disease who might be at risk for late recurrence. So then we would have an idea of who can be appropriately treated with only 5 years of hormone therapy versus a longer course. So that's already 2 inroads. And then there's additional data which suggests that we may be able to identify subgroups of patients with either triple negative or HER2 positive disease who actually do extremely well with minimal chemotherapy. And if we could do that, that's going to open up a whole new road of understanding of when less is enough chemotherapy. Keeping in mind that sometimes less is more, sometimes less is not more as well. And one of the examples of that is the HIMUS cooperative group trial called 49907, where women who were 65 and older received either AC or CMF chemotherapy versus capecitabine. And particularly in the hormone receptor negative group, the AC or CMF was significantly better than capecitabine. So in that situation, if the therapy doesn't work as well, it's not going to be as good as the standard treatment. Then I think that there are other situations where we have high bulk, high risk, triple negative or HER2 enriched disease where clearly we see a benefit from either the most intensive standard therapy or the addition of potentially multiple HER2 targeted therapies. So I think we're making great progress in trying to differentiate biologically the tumors, and of course we need progress in understanding how patients experience the treatments, how they metabolize these drugs, so-called pharmacogenomics. And we can add all those together, I think, in the future to try and better individualize treatment for patients. And individualizing doesn't always mean adding. Sometimes it means subtracting.